Okay, today we are going to do this non-articular rheumatism. There are two types, polymyalgia rheumatica and fibromyalgia. So we will do this and then the remaining topics, if we get the time to do, we will do that as well. Okay, so non-articular rheumatism is a disorder that primarily affects soft tissues or periarticular structures. They are affecting the soft tissues and the periarticular structures. And these structures, the soft tissues are bursitis, tendinitis, tenosynovitis, and fibromyalgia and PMR, just polymyalgia rheumatica. Okay, now polymyalgia rheumatica is characterized by pain and stiffness of the proximal extremities, girdle area. Polymyalgia rheumatica is characterized by what? Pain and stiffness of the proximal extremities, closely related to GCA. 15% of patients with PMR develop GCA. Okay, and there is no muscle weakness. Okay, yes, no, just a second. Okay. Someone is asking what is GCA? So GCA is giant cell arteritis. Yes, yes. It's giant cell arteritis, like 50% of patients with polymyalgia rheumatica, they will develop this giant cell arteritis. And this, this pain is characterized by pain and stiffness of the proximal extremities. That is the girdle area, which is, the hip base of your spine. Is basically that is your girdle area. You know, base of your spine and the lower area. So morning stiffness and pain, it's associated with pain, and 15% of patient will develop GCA. That is a giant cell arteritis. Okay, the morning stiffness duration is greater than 45 minutes. If it's present, then there are 2 points, points where abnormal. Okay, and hip pain or limited range of motion is there, then 1 point. Absence of RF or ECPA. Just okay, there will be the absence of rheumatic factor, and ACPA is anti-citrullinated peptide antibody. Okay, and then there is absence of other joint involvement. Okay, this is also 1 point, and at least one shoulder with subdeltoid and or bicep tendinitis and or glomerulonephrosynovitis, and at least one hip with synovitis and or uh, trochanteric bursitis on ultrasound. That's not available. Both shoulders with subdeltoid bursitis, bicep tendinitis, or glenohumeral synovitis on ultrasound. Okay, no. Okay, in this points without, if you're not doing, then ultrasound, then these are the points, like morning stiffness will be there, hip pain and limited range of motion will be there, absence of rheumatic factor or anti-citrullinated peptide antibody will be there, and absence of any other joint involvement. Then we have the point system over, and with abnormal this, then at least we having, because on the ultrasound we can see the inflammation of the surrounding areas as well. So there will be one point for them. And epidemiology is incidence is 50 and 1 lakh per year in those greater than 50-year-old. Age of onset typically greater than 50, and female to male ratio is 2:1. So this one is common in females. So incidence is 5 into 1 lakh, and greater than 51, and in females it's more prevalent. And constitutional symptoms prominent, like such as fever, weight loss, and relief. Pain and stiffness of symmetrical. It will be symmetrical proximal muscles, that neck, shoulder, hip, girdles, thighs, gel phenomena like stiffness around after prolonged activity. Okay, so the symptoms will be like the general symptoms, fever, weight loss, and malaise, and then the pain and stiffness in the neck, shoulder, and hip girdles or thighs. And the gel phenomena will be there. That is the stiffness after prolonged inactivity. Like the patient is sitting for a prolonged period of time and he's not doing any kind of activity, then there will be stiffness. Physical exam review, tender muscles, but no true weakness or atrophy. Okay, so on physical exam, there will be tenderness, like, there will be mild pain or tender area, but there will be no atrophy or exact true weakness. Okay, investigation, what we will do is that's the blood worker, which will show anemia of chronic disease, elevated platelet, elevated ESR and CRP, and normal CK up to 5%, and EMR reported with normal inflammatory markers. Okay, so anemia will be there. Platelets will be raised, ESR and CRP will be raised, CK will be normal, and up to 5% of PML inflammatory in 5% of cases reported with normal inflammatory markers. Okay, in 5% of cases, uh, this okay, sorry. Okay, so in investigation, there will be anemia, platelet will be raised, ESR, CRP will be raised, but creatinine kinase will be normal. And 5% of cases, inflammatory markers will be normal. Treatment is the goal of therapy is symptom relief. Okay, fine. We'll start with prednisone. And if there is no response within 7 days, then we will taper slowly with improvement over 1 year period with close monitoring. If inflammation taper until discontinued. Okay. Relapses should be diagnosed and treated on a clinical basis. Do not treat a rise in ESR as a relapse. Treat relapses aggressively. That's 15%. Okay, fine. It's the relapsing rate is 15%, and we have to, treat it aggressively. We will not take it lightly, and monitor for the steroid side effects. Okay, that is glucocorticoid-induced osteoporosis prevention and follow-up for symptoms of GCA, as we just studied above, that 5% of the patients will 50% of patients with VMR will eventually develop GCA. So the incidence is 50 in 1 lakh person. It's more common in females. Age is greater than 50. There will be uh, pain and stiffness of the neck, shoulder, and hip girdle and thigh muscles. There will be gel phenomenon, that is, stiffness after prolonged inactivity, sorry. And physical exam will show tenderness, but there will be no weakness or no true weakness or atrophy, and there will be the general symptoms that fever, weight loss, and disease. And on blood investigation, we will just see elevated platelets, ESR, CRP, and various creatinine kinase being, normal. And 5% of cases, inflammatory markers are usually normal. So the goal of the therapy is the treatment is to relieve the symptoms. So we will initially start with prednisone, and once daily reconsider diagnosis if no response within several days, which means that it will improve. Reconsider diagnosis if no response within several days. Okay, it will improve with prednisone, and taper slowly with improvement over 1 year period with close monitoring. If in remission, taper until discontinued. Okay, taper slowly with improvement over 1 year with close monitoring. That for the 1 year, we have to taper it slowly, and we have to closely monitor if in remission, taper until discontinued. So we will taper it until we have discontinued it. Relapses should be diagnosed and treated on clinical basis. Do not treat a rise in ESR as a relapse. Inflammatory marker can be raised, but it cannot be a relapse. Do not treat a rise in ESR as a relapse. And we have to do the clinical basis. Okay, fine, this was the chart and the symptoms, is everything is available, then okay, fine. We will say that now the patient is in a relapse state, and then we will treat the relapse aggressively, because 50% that there is a rate of relapse, and monitor for steroid. Again, wherever you go for, we give steroids for a longer period of time, they definitely monitor the steroid side effects, and also we will closely monitor and prevent follow for the symptoms of GSE. Now, fibromyalgia is the chronic, less than greater than 3 months, widespread, axial left and the right sided, upper and lower segment, non-articular pain with characteristic tender points. Okay, here we are getting the tender points. Fibromyalgia is chronic, greater than 3 months. It's widespread. It's axial, right and left sided. Okay, axial, right, left sided, upper and the lower segment. Okay, that was only the this proximal extremities, only the griddle area. This one is more widespread. It's axial, okay, and then pain with characteristic tender points. Okay, now this ACR preliminary diagnostic criteria for fibromyalgia is widespread pain index. Okay, symptom severity is, I think so. We will read here also, but this is the diagnostic criteria is okay. Right and left shoulder, girdle, upper arm, lower arm, hip, upper leg, lower leg, jaw, one area, chest, abdomen. Okay, fine. Widespread pain index greater than 7 and SS score greater than 5, or VPI 3 to 6 and SS score greater than 9. Okay. Symptom severity and symptoms have been present at a similar level for at least 3 months. The patient does not have a disorder that could otherwise explain the pain. Okay. Greater than 3 months, the symptoms are present, and the patient does not have any other issue that will explain the pain. So symptom severity is severity of fatigue, walking and refreshed cognitive symptoms over the past week instead of somatic symptoms. All at this is the table of arthritis. We just look into that. We just start with the epidemiology. So it's again more common in female. The ratio is 3:1. It's affecting 25 to 45% adult cells. Prevalence is 2 to 5% in the general population. Overlaps with chronic fatigue syndrome and myofascial pain syndrome. Okay, it's overlap with fatigue syndrome and myofascial pain syndrome. Let me see what is this syndrome. Okay, it's a chronic muscular pain disorder which affects any skeletal muscle in the body. It is the pain or inflammation in the connective tissue that cover the muscles, like the fascia. Okay, so it's a chronic muscular pain disorder of any skeletal muscle, and it's the inflammation, it's the pain or the inflammation in the connective tissue that covers the muscles, that is the fascia. Syndrome caused by a stimulus such as muscle tightness that sets off trigger points in your muscles. Factors, okay, myofascial pain syndrome should not be confused with fibromyalgia, which has similar symptoms. Fibromyalgia is a chronic condition that causes pain and tenderness throughout the body. Okay, so it shouldn't be confused. Localized trigger points, that is in effect that activate the pain muscle stiffness. Is that point which you don't have to. Yes, that this is a difference. Fibromyalgia is a chronic condition that causes pain and tenderness throughout the body, not just the particular area, and does not include trigger points. Okay, have both fibromyalgia and microcyclic pain syndrome. That makes it important. Okay, we'll just go through this once. Trigger points, like few localized trigger points, and here they will be having multiple generalized tender points, which is just read. Musculoskeletal pain will be localized and they will be generalized. Pain in different spot than its source, more frequent, it's less frequent. Fatigue less, poor sleep less, burning of tingling sensation is less, headache is less, irritable bowel is less, sensation of swelling is less, and all of these is present in fibromyalgia. So basically in fibromyalgia, it's a generalized, as we just said that it's widespread. So there is, tender points also, and the musculoskeletal pain is generalized, and pain in different spot than its source is less frequent. Like here, pain in different spot than its source. Like, okay, the source of pain is here, and I'm having and I'm having the pain here. That's more common in myofascial because it's the skeletal muscle pain. It's the inflammation caused by the it's the pain caused by the inflammation of the fascia covering the skeletal muscle. So this is the difference. Should not be confused with this, which has similar symptoms. It's a chronic condition that causes pain and tenderness throughout the body, not just the particular area, and does not include trigger points. See, here's a localized, like this lady is having the localized pain here, and they have the trigger points also. These trigger points radiate the pain to the affected area when pressure is applied to them, and sometimes spontaneously with no pressure. Sometimes this pain can be what seem to be unrelated to any part of the body. Okay, so coming back. Okay, so strong association with psychiatric illness. Okay, a widespread aching and stiffness, easy fatigability, sleep disturbance, symptoms aggravated by physical activity, poor sleep, and emotional stress. In fibromyalgia, if you're having poor sleep, you're having stress because it's strongly associated with psychiatric illness. Also, if you're having some kind of this, then the pain will be aggravated. Whereas in this polymyalgia, we were having what? Gel phenomena, which is after inactivity. And in this, we are having what? The pain is aggravated by physical activity. In fibromyalgia, the pain is aggravated by physical activity. Okay, the neurological symptoms of hypogesia, paresthesis, and allodynia. Let me just search these terms, that what exactly this means. Allodynia. Okay, allodynia is pain due to stimulus that does not normally provoke pain. An example would be a light feather touch. Okay, neurological symptoms will be there, like such as allodynia, which is the pain due to a stimulus that does not normally provoke pain. Okay, like even a feather is going, the patient's okay, fine, I'm going starting having a very severe kind of pain. And hyperalgesia is a symptom that causes unusually severe pain in situations where feeling pain is normal, but the pain is much more severe than it should be. So in hyperalgesia is, like for example, if you just got a pinch, it's a slight pain, but the patient with fibromyalgia will experience a more severe pain to that stimulus. Okay, and paresthesia we all know is tingling and pricking and needle type of pain. Okay, it's associated with what? Irritable bowel or bladder syndrome, migraines, tension headaches, restless leg syndrome, obesity, depression, and anxiety. Okay, physical exam should reveal only tenderness with palpation of soft tissues, with no specificity of Trigger tender points. Okay, physical exam should reveal only tenderness. Okay, with palpation of soft tissue. When we will palpate the soft tissue, like you will palpate, it will just reveal what the tendon is with no specificity for trigger and tender points. Okay, as we just read here, there are no trigger points in myofascial pain, whereas there are trigger points in, I think so, this sorry, fibromyalgia, there are no trigger points, right? They have no triggering factors. Yes. No, they have trigger points. Yes, in myofascial syndrome, also they have a few trigger points, but in fibromyalgia, there is a lot of trigger points. But while doing the physical examination, we will just, we will, there will be only tenderness, and there will be, with like no specific trigger or tender points will be there, but there will be tenderness on palpation. Okay, investigation, we will go for TSH, all typically normal unless unrelated underlying disease. Okay, serology, do not order ANA or RF unless there is a clinical suspicion of a CTD or inflammatory arthritis. Okay, laboratory is sleep assessment. Okay, because the pain is so severe. We just read here. Poor sleep. Okay, the sleep. So, everything is more frequent here, like burning, prickling, tickling, just paresthesia. And headache will be there, which we just discussed. Okay, depression, a headache will be there, tension headache will be there. Yeah, migraines will be there, irritable bowel syndrome and irritable bowel and bladder will be there, restless leg syndrome will be there, depression and obesity, anxiety will be there, and physical examination will only reveal tenderness with palpation of soft tissues. Okay, and blood pressure, blood workup is only TSH. Okay, all typically normal unless unrelated. Okay, and we do not have to order this if unless and until we are suspecting something inflammatory or arthritis. So we will not order ANA or RF. And laboratory assessment is sleep assessment. Sorry, sleep assessment. Okay, and the treatment is non-pharmacological therapy is graded exercise programs, including aerobic, and resistance training is greater than 8 repetition for exercise. Okay, aerobic and resistance training. Okay, non-pharmacological other therapies. Okay, acupuncture, CPT, hydrotherapy, mediated movement. Okay, yoga, and tai chi. Okay, acupuncture, CPT, hydrotherapy, and there is no specific evidence for biofeedback, chiropractic, therapy, and medicine. Okay, there is no evidence for biofeedback, chiropractics, and hypnotherapy and medications. So the treatment of IMAK is divided in two parts: non-pharmacological. Non-pharmacological is yoga, aerobics, and resistance training. Okay, CBT, because CBT acupuncture, and now the pharmacological training is tricyclic antidepressants, just amitriptyline for sleep restoration and selective with those anticholinergic side effects. Okay, SNRIs, dulzidine, and the anticonvulsants, pregabalin and gabapentin. Analgesics may be beneficial for pain that interferes with sleep, that is NSAIDs, not narcotics. Okay, variable, usually chronic, waxes and wanes with some pain and fatigue that usually persist. Okay, problem is variable. It's usually chronic. It comes and goes with some and fatigue and pain that persists. Right? Back and forth. And here it is clinical features of inflammatory myopathy versus polymyalgia rheumatica versus fibromyalgia. Okay, we will do this. And okay, polymyositis is more common in females. This one is also more common in females, and fibromyalgia is also. And polymyositis is 40 to 50. PMR is greater than 50, whereas this is in the young adults, 25 to 45. Muscle involvement is proximal muscle. Again, this one is proximal and this is diffused. Okay, weakness, yes. No, I know, because we just read there is no true weakness available, and no true weakness will be seen in this polymyositis. Weakness will be there, pain and stiffness will be there. Okay, pain. It will be polymyositis. It will be painless. A PMR painful. Again, this will be painful. Stiffness present. It's morning stiffness will be there. Shoulder this may have morning stiffness. Investigation, muscle biopsy, creatine kinase EMG, rule out malignancy. ESR, CRP, rule out giant cell arthritis because it's very common because 15% cases they will get sleep assessment and DSH. ESR and this usually normal. It will be elevated along with platelets and will be having anemia as well. And fibromyalgia, it will be normal. Treatment is high dose steroids and immunosuppressants. In this, we're giving a low dose steroids like prednisone, and here exercise, sleep restoration, anti convulsants, anticonvulsants, and everything we are giving over here. Okay, so okay, now we are going to read this common medications. The common medications of osteoarthritis, analgesics, acetaminophen, Tylenol. Okay, and it's the first line. Okay, and analgesics, acetaminophen, and Tylenol, it's the treatment, is the first line, and the contraindication is severe liver disease, or severe liver impairment. Okay, adverse effect is hepatotoxicity, overdose, potentiates warfarin, potentiates warfarin. I'm unable to because it's not that clear. Okay. And then the NSAIDs, which is ibuprofen, diclofenac, misoprostol, naproxen, meloxicam, and these are the medical names. Advil, which is very common, Motrin also very common. This is second line. Okay, first line is Tylenol, which is acetaminophen in any kind of osteoarthritis. And but in Pakistan, I have seen many people giving, with Diclo and Brufen. Sorry, Diclo and this naproxen. You did before more. So the contraindications are GI bleed, renal impairment, allergy to ASA, NSAIDs, pregnancy, and anticoagulants. It can cause adverse effect, nausea, diarrhea, vertigo, rash, dyspepsia, okay, PUD, okay, yes, PUD is very common, hepatitis, renal failure, hypertension, nephrotic syndrome. So if you are just giving this, then for a prolonged period of time, then we have to, give omeprazole, something for PUD. Also look out for liver function test, check the blood pressure and the kidney function test as well. Okay, COX-2 inhibitors, that is, yeah, selling is okay. Just a second. Okay, so celecoxib and it indications dyspepsia and GERD. Okay, fine. Renal impairment is the contraindications and cardiovascular disease and GI bleed, and same as answers above is the adverse effect, that is nausea, diarrhea, vertigo, rash, dyspepsia, GI bleed, PUD, hepatitis, renal failure, hypertension, nephrotic syndrome. Okay. Other treatments are combination analgesics, that is acetaminophen plus codeine plus or acetaminophen plus NSAID, enhanced short-term effect compared to acetaminophen alone, more adverse side effects, sedation, constipation, nausea. Okay. Corticosteroid injection short term, decrease the pain and improvement function used for the management of inflammatory uh, process while infection has been ruled out. Okay. Hyaluronic acid used for mild to moderate osteoarthritis of the knee. However, life-supporting evidence and not considered to be effective. Okay, precaution with chicken or egg allergy. Okay, topical NSAIDs, topical diclo may be used for patients who fail acetaminophen treatment and who wish to avoid systemic therapy. Better on small joints. Okay, for topical NSAIDs can be given for the small joints, it's better. And in people who prefer topical treatments to of systemic treatment. Capsaicin cream, mild decrease in pain. Okay, that's also effective. I have seen patients using this. Glucosamine sulfate plus controlin, limited evidence of benefit. Okay, no regulation. Okay, fine. Okay. We will not read about this. So the combination therapy is, but the side effects will be enhanced. The corticosteroids stand short term, and it will decrease the pain and it improves the function of your joint, but used for management of an inflammatory process when infection. Okay, you will go for the inflammatory process, and but before that, we have to rule out that this patient is not having any kind of infection. Hyaluronic for mild to moderate of the knee, osteoarthritis. Okay, and while we are giving this, we have to look, precaution with chicken and egg allergy. Okay, and says and this. Okay, then again, DMARDs, hydroxychloroquine, retinal disease, and G6PD deficiency, GI symptoms, skin rash, macular damage. Neuropathy requires annual ophthalmological screening to monitor retinopathy. Okay, fine. If we are giving this hydroxychloroquine, then we have to annually monitor or look for this, go for this ophthalmological exam, sulfasalazine and ASA or kidney allergy. Okay, again, kidney disease, allergy and G6PD deficiency, GI symptoms, rash, and leukopenia are very common in this. Methotrexate, which is normally given, bone marrow suppression, liver disease. We will not give in the person who have a bone marrow suppression, liver disease, or lung disease, and oral ulcers, GI symptoms, cirrhosis, myelosuppressions, and pneumocystis and tuberculosis process. And I just read that if you're giving methotrexate, then you have to give folic acid throughout because it causes anemia. So leflunomide, liver disease, lung disease, pregnancy, alopecia, liver dysfunction, interstitial pulmonary fibrosis, and hypertension. Leflunomide is contraindicated in liver disease. This one is also contraindicated in liver disease or bone marrow suppression. And the lung disease, both are same. The pregnancy also, this one, methotrexate also, leflunomide also. Okay, and this is the side effects. And not commonly used, and we will leave this one. And again, the DMARDs, the new DMARDs is etanercept, infliximab, adalimumab, golimumab. This one is very much commonly used, rituximab, tocilizumab. I have seen patients using this. It causes B cell depletion. This is something important. Rituximab causes B cell this. And yes, and then landmark rheumatological trials, comment, purpose, infliximab, this purpose to assess infliximab. Okay, I don't think so. This one is very much important. Hyaluron title, this purpose, this, but that's not. This is nothing. And in the end, there is references. So this is also what we are not going to do. So what we did today is fibromyalgia, this polymyalgia, and it was pretty easy topic. We have done. Just let me check what's remaining now. We have done gout, pseudo gout, the topics of last week. We will just do one. the topic of 13. Scleroderma we have done. Inflammatory myopathy we will do. Okay. We have done this. The scleroderma we have done. Okay, we will do just the inflammatory myopathy. Okay, it's the or this Georgian syndrome. Okay, we will do this first, then we will go on. Okay, Sjogren syndrome. Sjogren syndrome is autoimmune condition characterized by dry eyes, keratoconjunctivitis, Zika, xerophthalmia, and trauma, xerostomia caused by lymphocytic infiltration of salivary glands and lacrimal glands. Okay, it's an autoimmune condition which causes dry eyes, dry mouth, and both of these are caused by what? Lymphocytic infiltration of what? Salivary glands and the lacrimal glands. Exists on spectrum and may evolve into a systemic disorder in 20% cases with diminished exocrine gland activity and extra glandular features, primary and secondary forms. Okay, it's associated with RASLE. HIV prevalence is 0.5% in females. It's more, and the ratio is 10:1. Again, it's more in females, and the age is 40 to 60. Increased risk of non-Hodgkin lymphoma, lifetime incidence is 6 to 7%. Okay, it's an autoimmune condition characterized by di-eyes, which is keratoconjunctivitis, Zika, xerophthalmia, and dry mouth xerostomia caused by lymphatic infiltration of salivary and lacrimal glands. It exists on a spectrum, and they may evolve on this, they evolve into systemic disorder. In 20% cases, either it's limited or it will evolve as systemic disorder and diminished exocrine activity and extraglandular function. So it exists on a spectrum. Like it is, it varies. In 20% cases, it may become a systemic disorder. Okay, and it's more common in females. And the age is 40 to 60 years old, and it's associated with rheumatoid arthritis, SLE, and HIV. And the criteria and the scores are labial salivary gland biopsy with focal lymphocytic focus. Their score is 3, and DSSA or RO positive is 3. Ocular staining greater than 5, it's 1. Schema disease, okay, 5. Storage test, Schimmer's test is 1. It's just to check the eyes. And unstimulated whole saliva flow, the point is 1. Okay. So this is the criteria and this is the score. So labial salivary gland biopsy, and if it's showing lymphocytic, again, it's very blurred for me to read, and so the score will be 3. Let me see. Okay, it's like lymphocytic with focus score greater than 1 per 4 millimeter square, I think so. Focus scores are histopathological grading systems strongly associated with phenotypic, ocular, and serological components of geology. Okay, what I was going for. Okay, and then we will do this Schimmer's test of the one eye, and if it's less than 5 millimeter per 5 minutes, then the score is 1. It's just to check, this test is to check the tear production, and unstimulated saliva flow rate we check without any stimulant. We will check how much the person is producing the saliva. Okay. Clinical presentation is Zika complex, that is dry eyes, dry mouth, complicated by staphylococcal blepharitis. Okay. Dental caries, oral candidiasis, angular cheilitis. Again, it's all because of dry mouth and everything. Extra glandular manifestations, fatigue, low-grade fever, autoimmune thyroid dysfunction, arthritis, some clinical diffuse, renal disease, glomerulonephritis, pathological vasculitis, peripheral neuropathy, lymphoma risk is increased. The classic triad, 93% of patients of Sjogren's syndrome patients will have dry eyes, dry mouth, which leads to dysplasia and arthritis. That is small joint asymmetrical non-erosive, but may be associated with rheumatoid arthritis. As we just read above, that it can be associated with rheumatoid arthritis, with SLE, and with HIV, in which case the arthritis is erosive and symmetric. Okay, if it's not associated with rheumatoid, or then it will be asymmetric and non-erosive. But if it's associated with rheumatoid, then it will be erosive and symmetric. And the triad is dry eyes, dry mouth, arthritis, and known as complex also, dry eyes, dry mouth, and which is complicated by staphylococcal blepharitis, that is the infection of the eye. Yeah, it's the common conditions, the blepharitis, infection of the eye, then again the dental caries, oral candidiasis, angular cheilitis, inflammation at the face ring, at the labial commissures of the mouth. Okay, so these are very common, presentation. An extra glandular manifestation will be fatigue, low-grade fever, thyroid dysfunction, arthritis. We just read here. Okay, arthritis will be present. Okay, dry cough will be there. Chronic dry cough will be there. Subclinical diffuse xerotrachea leads to chronic subclinical diffuse uh, interstitial lung disease, xerotrachea leading to chronic cough, chronic dry cough, renal disease, glomerulonephritis. Okay, firstly, dry eyes, dry mouth, blepharitis, dental caries, oral candidiasis, angular cheilitis, fever, fatigue. Okay, thyroid dysfunction, arthritis, dry cough, renal disease, glomerulonephritis, peripheral neuropathy, and the risk of lymphoma is greatly increased. Treatment for ocular artificial tears, tear gel is severe, moisture retaining eyewear, humidifiers, or surgical partial occlusion for dry eyes. Okay, artificial tears or gel, humidifiers, moisture retaining eyewear, and or surgical functional operation for dry eyes. Oral good dental hygiene, hydration, avoid alcohol and tobacco. Okay. Parasympathogenic agents that stimulate salivary salivary flow, that is pilocarpine. Yes. Pilocarpine, topical nystatin or clotrimazole for candidiasis. Systemic treatment, hydroxychloroquine, corticosteroids are ineffective. Rituximab can be used in severe organ-friendly disease, that is vasculitis. Rituximab. Rituximab, we just read here, is the most the DMARD introduced one. I think so. We were just reading something very important because that was causing rituximab. I just read here somewhere. Oh, it's not the DMARD. So which one was causing beta cell? Okay, yes, rituximab causes B cell depletion. Yes, it's a DMARD. Causes the B cell depletion. So we were just we will give so the treatment for that is symptomatic, that is the patient is having dry eyes. We will give the gel or the artificial tears, eyewear, and good dental hygiene, hydration, or avoidance of alcohol and tobacco, drugs that will increase pilocarpine, that will increase the production of saliva, the statin for the candidiasis, and the systemic is rituximab, which is given in severe organ-threatening disease, that is vasculitis, and systemic treatment that is, but they are ineffective. Systemic treatment are ineffective, that is hydrocortisone and corticosteroids, but rituximab can be given. Although this one, but they are infective, but this can be given in severe life-threatening disease. Okay, mixed connective tissue disease, that is the syndrome with features of three different connective tissue disease, that is essentially myositis. Common symptoms, Raynaud phenomena, and swollen fingers. Okay, so we just read that Raynaud phenomena is a phenomena in which our fingers turn blue. Okay, it's the phenomenon and the condition which the blood vessels of the extremities narrows, restricting the blood flow. Okay, and sometimes it involves our ear and nose also. So that's the Raynaud phenomena, and the swollen fingers in some cases, blood. Yes, and it can be triggered by cold, stress, or emotional upset. So mixed connective tissue syndrome is the syndrome with three different features. That is SLE, scleroderma, and myositis. Common symptoms are Raynaud phenomena and swollen fingers. Okay. And then when investigation, we will do anti-RNP. Treatment is generally guided by severity of symptoms and organ system involved. Prognosis is variable. Some individuals go into remission, others develop a distant connective tissue disease, that is SLE, and others develop a severe disease course, that is pulmonary arterial hypertension is the major cause of death. Okay. Okay. So some individual goes into remission, other may develop severe connective tissue disease, that is SLE or systemic sclerosis, and others develop a severe disease course. And pulmonary arterial hypertension is the main cause of death in connective tissue disease. Okay, it's a combination of three connective tissue, that is SLE, scleroderma, and myositis. The common symptom is Raynaud phenomena and swollen fingers. Investigations NTR&B. Treatment is okay, fine. Prognosis is remission, SLE or this. And if we just go and revise scleroderma once more, then we go get a clear picture. So scleroderma is non-inflammatory autoimmune disorder characterized by widespread small vessel vasculopathy, production of autoantibodies, and fibroblast dysfunction causing fibrosis. Basically, in this condition, it's a widespread disease of small vessel, and fibroblast, autoantibodies, and eventually fibrosis is happening. Calcinosis, Raynaud phenomena, esophageal dysmotility, sclerodactyly, and telangiectasia. Okay, it's two types, localized and generalized. Localized is in children and young adults, and in localized, no involvement of internal organs. Internal organs are not involved, and it's most common in young adults and children. And morphia and linear hard oval patches on the skin. Okay, yes, we just saw that day. I will show it again. Morphia. Yes. It's these are the round patches. These are the patches of morphia. Morphia, that's hard oval patches on the skin, linear line of thickened skin. Okay. Scleroderma are of two types. It's non-inflammatory autoimmune disorder involving small vessels, causing the production of autoantibodies and dysfunction of fibroblasts, which leads to fibrosis. It's localized. Localized is more common in children and adults. They are localized has two types. It's the morphia, that's the hard oval patches of the skin, and thickened lines the linear is on the skin. Now generalized. Generalized is limited and the diffuse. Limited is skin sclerosis restricted to hand, face, and neck. Okay. Third to fourth decade. Okay. Pulmonary hypertension is common, and then the crest. Crest is in the limited systemic sclerosis, and the generalized one, diffuse systemic sclerosis, widespread skin disease. Okay. Proximal to wrist. Okay. Can involve trunk, tendons, early visceral involvement, renal, pulmonary, and pulmonary fibrosis. Okay, scleroderma is the most common cause of secondary Raynaud phenomena. Okay, scleroderma is the most common cause of secondary Raynaud phenomena, and crest is included in this limited systemic sclerosis, which is the mnemonic of calcinosis, Raynaud phenomena, esophageal dysmotility, sclerorectal, and telangiectasia. So the generalized one is limited and diffuse and limited. The skin sclerosis is restricted to hand, face, and the neck. It happens in third to fourth decade. And pulmonary hypertension is very common, and the crest syndrome is there. Whereas in the diffuse one, it's a widespread disease. It's proximal to the wrist and can involve the trunk as well. Trunk also and proximal to wrist. And tendons and early visceral involvement, that is the lung and the pulmonary fibrosis. So it's proximal to wrist, like our fingers are not involved in this. If we just go, there is proximal to wrist.
So the digits are not involved, I think.
Yes, the fingers, the digits. And it can also involve our trunk also and tendons also. Like it's above, it's our palm and above. Not the fingers are not, like the digits are not above. The proximal row and okay, it was not involved. Okay, then etiology is idiopathic vasculopathy, not vasculitis leading to atrophy and fibrosis of tissue. We just read that, characterized by several hallmark pathogenic features, and that small vessel vasculopathy resulting in tissue hypoxia. Okay, small vessels are involved tissue hypoxia, production of autoantibodies, fibroblasts dysfunction leading to increased deposition of extra-articular matrix. Resembles developing hypertension. Lung disease is the most common cause of morbidity and mortality. Okay, because we just read, okay, pulmonary hypertension is very common. So lung disease is the most common cause of morbidity and mortality. And in connective tissue, we just read that, the most common cause of death is this, what is, yes, pulmonary artery hypertension. And in mixed connective tissue, also scleroderma is involved. So yes, and scleroderma also, it's what? The main cause, lung disease, the main cause of mortality and morbidity. So malignant hypertension, fibroblasts, again, it's the same thing. If we just read about this Raynaud phenomena, cold hand, fibrillary obstruction, occupational, lupus erythematosus, and connective tissue disorder, DM drugs, hematologic problems, that is polycythemia, leukemia, occupying arterial problems, okay, atherosclerosis and anorexia nervosa, okay, is to anorexia, arterial, okay, neurologic problems, that is muscular tone, disease of unknown origin, okay. Raynaud phenomena diagnosis is cold hand, and the cold hand stands for cryoglobulin, obstruction, occupational, okay, lupus erythematosus, DM drugs, hematologic, that is polycythemia, arterial problems, atherosclerosis, anorexia nervosa, neurological problems, that is muscular tone, disease of unknown origin. Okay, the scleroderma is again more common in females. The ratio is 3 to 4:1, peak in fifth decade, and we just read here. This one, the diffuse one, is common, generalized. Limited is common in third to fourth decade, so it's the fifth decade. Okay, associated with HLA-DR1 and environmental exposures, that is silica, epoxy resins, toxic oil, aromatic hydrocarbons, and polyvinyl chloride. Okay, it's associated with HLA-DR1 and the environmental exposures, that is silica, epoxy resins, toxic oil, aromatic hydrocarbons, polyvinyl chloride, and limited systemic sclerosis. Limited systemic sclerosis has a higher survival prognosis than diffuse. Okay, greater than 70% at 10 year, and that is 40 to 60% at 10 year. Okay, so the prognosis, the survival rate of limited is more than the diffuse one. The limited is confined to head, hands, face, and neck. Pulmonary hypertension is common, and the CREST syndrome is there, which is calcinosis Raynaud phenomena, which is metabolically occupied. Diffuse is widespread, proximal to wrist, can involve trunk and tendons, and causes renal and pulmonary fibrosis. That survival, the survival prognosis is 40 to 60% at 10 year, and the limited one is greater than 70% at 10 year. Okay, the investigations is blood workup, CBC, creatinine, okay, anti-topomerase, antibody, CREST, limited, okay, anti-centromere antibody, anti-RNA polymerase, antibody, BFT, SS, and monitor ILD. Okay, rule out pulmonary hypertension, baseline chest X-ray to rule out interstitial lung disease, pulmonary function test, and interstitial lung disease. Okay, because lung is involved, pulmonary hypertension, lung fibrosis is there. Okay, fine. Treatment dermatological is good skin hygiene, low dose prednisone. Okay, method 3 said limited evidence, vascular, Raynaud, keep hands and body warm, smoking cessation, vasodilators, and GERD, PPIR first line, H2 receptor antagonists, small bowel bacteria overgrowth, renal disease, ACE inhibitors for hypertensive crisis, pulmonary is early tissue disease, okay, hypertension, vasodilators, okay, rapidly progressive disease at risk of organ failure, consider hematopoietic stem cell transplantation, cardiac pericarditis, systemic steroids, musculoskeletal arthritis, NSAIDs, and myositis, systemic steroids. So these are the treatment options. Good skin hygiene, derma prednisone, keep hot, vasodilators, PPIs, AC inhibitors, pulmonary is vasodilators, cyclophosphamide.